Carl? Carl? Hello again and welcome back. I hope everyone's feeling recharged as the afternoon will continue to deliver some. All the content will be available to view on demand within 24 to 48 hours. So don't worry if you've missed something earlier. Data sent through procurement will be accumulated through 3 collection points on the NHS Spend Comparison Service. This is designed to help providers understand product variation across medical disciplines and assist providers across ICS to make for a more economic healthcare system. The gathering and analysis of spending data is essential for the procurement of data, ensuring the success and development of the NHS. By working towards a net zero healthcare system by 2045, the NHS supplier roadmap is designed to make a success of those ambitions. By 2027, suppliers will have to release emissions reports to the public, as well as create a plan which ensures the reduction of pollution. These reports must include their direct and indirect carbon contribution. Well, let's talk about how the use of data and information will improve the standard of delivering procurement throughout the NHS. I'm delighted to say that on this panel, we have Sarah Ford, Strategy Executive Director, NHS Supply Chain, Niels van der Winkel, Head of Procurement Data for NHS England, and Steve Balding, Commercial System and Data Strategy Programme Director at the Department of Health and Social Care. Lovely to, she says, putting on her glasses. Now it's lovely to see all three of you. Thank you very much for joining us and for kicking off the afternoon session for us. Niels, I'd like to start with you, if I can, with a suggested question that you put forward actually to kick off this panel with, and then I'd like to get Sarah's views and Steve's views. So in the light of the current landscape with the increasing collaboration through integrated care systems, upcoming procurement rules reform, increased efficiency targets, it's a big question. What do you see as the national priorities in relation to procurement data and technology? Oh, we just need some sound, Niels. Hold on, I haven't got sound in.
Can you hear me now?
Yeah, we can hear you now.
Fantastic. Yeah, so in terms of the key priorities, when we talk about the national picture, if we break them down or if we bucket them simplistically, I think there's 2 key fundamental priorities nationally. First and foremostly, it really is in order to identify and drive collaboration across integrated care systems, it is essential that we understand in an ICS, what are we planning to procure? What are our contracts that are coming up for renegotiation? So we need that visibility, that forward visibility into planned commercial activity. So we need that pipeline data, we need that contract data, and we need to be able to see across an ICS, or ideally regionally and nationally, what are we planning to buy? That will help us to collaborate and drive better procurement outcomes. So that's almost like the first bucket, really. The second then is actually closely related to that, and that really stems from increasing regulatory requirements. But also in order to address our net zero targets, we need to have greater visibility into our supply chains. So we need to not only understand who are our tier 1 suppliers, but our tier 2 suppliers, tier 3 suppliers, where are they located? Are they doing everything they can and they should to eradicate modern slavery in the supply chains? Do we understand emissions that are being generated across our supply chain? So we need more data and more visibility across our supply chain and suppliers, but we also need to give them more visibility into our commercial activity and planned commercial activity, which will allow them to create better commercial propositions for the NHS and be able to bid to in the most effective way. So I think those are some of the key priorities really nationally.
That makes a lot of sense, and I like the way you broke it down there. Sarah, do you want to take up what Niels said and add your thoughts to that?
I think Niels has provided a good framework. I think if I put my supply chain hat on, I would say the number one thing we are discussing with customers and trusts and ICSs at the moment is around resilience, and I think that probably speaks to the second part of what Niels was talking about. It's still a very challenging supply chain landscape at the moment, and data and visibility of data across the system is really what will unlock that for the longer term. And I think what we're trying to do is increase mapping, increased insight into alternative products, as much transparency and upfront information sharing as we possibly can. But we are an ecosystem, both as a health service and with our suppliers. And only when you start to join the dots from a data perspective will you really have that one sort of fixed for the longer term.
It's funny, ecosystem is a word that times actually already this morning, and particularly in keynote presentations when you've sort of seen the slides to map out just what an ecosystem this really is. Steve, with your department hat on, what would you like to add to those first thoughts?
Yeah, I think from a commercial system and data perspective, I'm old enough to remember when Excel arrived into business.
Oh God, so am I.
Right, it was transformational in the way that you had rows of data and content in the system. Things have moved on. It's not 1984 anymore. And yet I still see organizations that are trying to manage really important activity through Excel and email. Now,
really,
what I really would say that, even organizations such as Cabinet Office, if I dare say it, they'll have a great idea to generate some data, and they will send out an Excel template and say, please fill this in, and then return it. And in the past, we may have seen Department of Health do that. Please send us the data in. Pandemonium ensues. I term it as Excel hell. The data will always be poor quality. People will lose data out of Excel. It gets sent around. People change the spreadsheet. So I would say use a fit for purpose system that works, whatever that system is. If you can get the right data in the right system to a good data standard, you are really on the way to success. From there, you've got some data that's good quality, poor quality as well. You can identify and work out where to improve the quality, enrich it until you have got insightful business intelligence. So that, for me, for anybody thinking about this, get away from Excel if you can. It's a good starting point, but get to a good system to manage that data.
We must be at the same age ballpark, Steve. I think my children, when I was working at GMTV many, many moons ago, that I remember somebody actually teaching me to send an email, and actually me asking, I don't really understand, why do I need to send an email? I mean, that really, sorry, is really dating me. A fit for purpose system, Niels. I saw you nodding away when Steve was talking about a fit for purpose system. That is really important, isn't it? All jesting aside.
Yeah, definitely. And I think this is really where we, so one of the many hats that we've got on as NHS England is also collecting certain data sets. And unfortunately, some of those data sets are still collected in Microsoft Excel format or CSV. That is really not ideal. Ideally, we are all on systems that either speak with each other or at least are configured to a common data standard so that we can actually aggregate that data more efficiently without manual intervention locally at trusts. So really a lot of focus that we've been putting on over the past 12 months has really been around looking across the commercial life cycle. We know NHS supply chain, big focus on the ordering and the delivery side of it as well, but actually thinking about some of those legislative changes coming in and really the ability to collaborate, understand our contracts in place with suppliers, working together with the HSE and other arm's length bodies and NHS providers, really shown a light on a necessity to have a high quality system, a system that allows us to undertake the planning of procurements, the running of procurements, and managing our contracts and our supplier relationships through a system of a specific, I would say, standard. So a lot of work had been done under the, well, actually, Steve is best talking about this, around actually going to market for that solution and bringing that single solution to the NHS. And that's really what we're working together with DHSC and the system supplier Atomis to roll out a single e-commercial system. So the source to contract system Atomis, which has a lot of benefits in terms of doing things in a more consistent way, having that data live in a single data set or database, so that we can drive more effective analysis and insights from that data. Because at the end of the day, that's really what it is about. It's allowing us to undertake our procurement activities compliantly and efficiently, but also to use that data to generate intelligence and insights around where can we and should we be collaborating where can we drive greater savings?
Debbie, I'll just read her comment on the question. She says that she's shocked after her own research how much the NHS is still relying on Excel, with staff having to produce spreadsheets in their own time, actually. Sarah, I'll come to you in a sec, but I just wondered if Steve wanted to add about anything on the rollout of that single solution to the NHS.
Yeah, very happy to. So around 3 years ago, I realised that the Department of Health and arm's length bodies such as NHS England, NHS Digital, they were all using their own local system to do the same thing. So I agreed to implement a solution that would, for those organisations, replace local systems with a single strategic system. It worked well. The different organisations collaborated, agreed data standards, etc. And we saved some money because one large contract with a supplier was less than several smaller contracts. We made sure that the contract and the arrangement was available to anyone else in health, and I say that in inverted commas, and basically UK public sector, NHS, ICS, ICB, NHS supply chain, anyone that would like to use that system. Since then, 110 organisations have decided to onboard and are using the system. I've managed to secure with my colleagues and Nils and others central funding for that platform, so anybody in the NHS can onboard without a charge. Hopefully, that's good news for everybody. What I really am trying to do with this whole thing is just make people's lives easier. If you think you need a commercial systems and data strategy, you can create your own. You can think about how to develop it, or you can just join ours. If you're thinking about buying a system, instead of doing that, you can just use ours. It's configured, it's set up. We're just trying to make it as easy as possible to help and facilitate this kind of data aggregation, data sharing, collaboration agenda together.
Just briefly, Steve, Jane says that she agrees with Niels and you about the value of common systems, but it can be really tricky. Systems are introduced without robust training packages, though. So does it come with a training package? Yeah,
that's a fair comment. Our implementation includes webinar-based training. It also includes video guidance, long videos end-to-end, how to manage tenders, also short 3-4 minute YouTube style videos if someone wants to get a contract signed through DocuSign, that kind of thing. It does include training. In my experience of all of these kinds of systems, sometimes people do not get chance to watch all of the training videos, the training content, attend training. Actually, they might log into the system. It's inherent enough in some places for them to just get along and use it. But I do recommend any similar system that people do try and attend that training and go into the implementation of using it informed. So that's my view on training.
Jane says perfect. Thank you. So that's great. Sarah, there is significant financial pressure across the government, facing the NHS, actually facing all of us right now. How does NHS supply chain use the spend comparison service to support its work in securing the best value products for the NHS and to help trusts really have an understanding of what those opportunities are?
Yeah, and I'm sure Nils and Steve will have points of view on the spend comparison service as well. But so this is obviously a tool not owned or operated by us. It's actually operated, I think, by NHS England, NHSX. But it's really integral to how we go to market to source on behalf of the whole NHS. I guess we're here to make sure that we can leverage the spending power of the NHS nationally, where there are categories that lend themselves to national procurement. And I'm not saying everything does, but where it does, we need the right tools and insight to be able to do that. So this tool really helps us both from the point where we're trying to create the category strategies, evaluate the market, benchmark what prices are out there at the moment. So that sort of procurement side of things, as well as helping us engage with trusts, with ICSs, to present opportunities and to show them the art of the possible, and pinpoint where those financial opportunities might be. I think one thing I would say, though, is with all data, you need to understand the context of the data and how it's been assembled and provided. And in some cases, sort of the constraints and the parameters you need to sort of apply to interpret the data. So I think we tend to use the spend comparison service as a directional tool for pinpointing and deepening conversations. But where you buy a widget and you get a training package attached, it's very difficult to look across the breadth of the prices and distill what the differences are. So it's a really powerful tool, and we're supportive and going to continue to really leverage that. But I would say, just approach it with the full understanding of what it does and doesn't contain.
I think
Neil? Go on, Steve, you add, and then we'll move to Neil.
Sarah raises a really good point there, that it is whatever system you are using and whatever data set you've got, it will give you some insights. The openness platform, for example, for a supplier, it will show you information through various different lenses of their contract estate, their potential for failure, that kind of thing. But you need a human to look at it and assess it and look out for errors in what the data is telling you. So we need these procurement category strategy experts to look at that data and go, actually, based on this, based on my experience in this sector of energy, etc., this is what we will do. So it's only part of the puzzle that I'm sure that supply chain are using.
Niels?
Yeah, I mean, NHS supply chain is one of the major users of spend comparison service. So spend comparison service is one of the products or product groups within the domain that my team manages. So NHS spend comparison service had been developed very much originally as a price benchmarking solution. Because of the beauty of the decentralized nature of the NHS, we all go to market for our own products. We all buy our own products through whatever routes we deem fit. Making it sound worse than it is, of course it isn't. But fundamentally, that leads to price variation. That gives an opportunity for NHS suppliers to also look at different ways of pricing for different NHS trusts. So what NHS spend comparison service purchase order dashboards do, they collect all of that purchase order data from NHS providers, normalizes that by SKU, by pack sizes, etc., and then looks at price variation based on volumes that are being procured. So that as a procurement professional, whenever you get a quote in from a supplier and you've got the manufacturing product code, you can get a sense of actually, is that price based on the volumes that you are looking to buy a sensible quote, or actually are there much better prices that are being achieved by other NHS organizations? So that's one aspect, and that's also very much how NHS category towers use it, or NHS supply chain, to make sure that the category towers are delivering on their savings objectives and targets. But that only really gives you the angle or the lens of purchase order data. Now, that, as both Sarah and Steve mentioned, is good for some types of analyses. What it doesn't do, purchase order data, doesn't really give you visibility into services expenditure that well, or certain unquantifiable or difficult to quantify procurement expenditure. So for that, what we've been focusing on, we built a new product, which is the spend comparison service accounts payable or spend visibility tool. So building and enriching that product ecosystem that will give visibility into actual invoiced spend. So that is not based on purchase order, but on invoice spend. And that really gives us a rich picture of total spend by normalized supplier. Because again, most organizations have a different finance system. You might call it in your finance system J&J Ltd. I might call it Johnson & Johnson Limited. Steve might call it something completely different again. But actually, we're all paying the same supplier. So how much is the NHS spending with a certain supplier? We need that AP data, and that's what that product does. And again, if you're working as an ICS, you're looking at for areas of collaboration. Using that tool will help you drill down on what categories of spend and what are our major suppliers where we have commonality of expenditure, and then diving into the detail of, okay, if we all use supplier X and we use products ABC, but you do use products A, B, D, can we all use products A, B, and C and reduce the variation? It's basically, again, it's providing that intelligence to make informed procurement decisions, which not only and not always are about driving cost out, yes, important aspect, but it's also reducing clinical and product variation in the clinical pathways. And it is also providing visibility into the risk exposure that we have in our supply chains and dependencies.
That was a very full answer. Thank you for that, Niels. Just moving slightly away, Steve, can you just explain to us what behavioural changes in the move away from many local systems to a few strategic systems? What sort of what behavioural changes result in that move?
Yes, if we look at the procurement space, In the past, a long time ago, people were sending out tender requirements, things like that, through email, even through paper notifications, things like that. We've moved towards a digital environment where suppliers bid, etc., through commercial systems, and we store all the data in there. In the past, we've had lots of local systems across health and actually across government. That causes challenges for suppliers, because every time they want to put a bid in with a company, they've got to go through a new portal. They're often coded differently. The individuals in the buying organisation, you will always find that there is one unlucky person that's been volunteered to look after that local system that 30 people are using. They're doing it off the side of the desk. Basically, they hope for the best and things go wrong. You also find that every new procurement policy notice that comes from government that applies for to your organisation, you've got to interpret that policy requirement and implement it with your interpretation. And inevitably, NHS England, NHS Digital, an NHS provider will interpret that slightly differently. Moving to a single system or to less systems means that we're doing things once in that system. So the new procurement legislation that we may talk about, for me, Nils, other people in the centre, and actually NHS providers that are interested in that agenda, that have got experts that can support it, will really welcome their input to say, this is a new requirement, something around barring suppliers that are not good corporate citizens. How will we implement that together, and how will we do it once? So for me, that's the big change that we're seeing, moving from lots of local systems that are done off the side of a desk to central systems which are supported properly, a service is managed properly, and we're implementing things through a proper roadmap.
And just a follow-up to that then, Steve, how do you deal with individuals who say that they have special or specific needs when you're trying to implement a central or a standard system and data set?
Yeah, every organisation, and I say this in terms of this, over 300 organisations that are eligible to use the platform that Nils and I are providing. Everyone's special in their own unique way. They've got their own requirements, but we're fortunate enough that we're getting better legislation from Cabinet Office where they recognise let's have a standard. We're seeing things such as the sustainability carbon reduction plans, where they are it's well set out legislation that considers the need for good quality data. So when somebody says we are special, and in our world, vacuum cleaners are king, and therefore let's put lots of fields around vacuum cleaners, vacuum cleaner servicing, vacuum cleaner management, we can say, well, actually, that might be locally important, but for the good of everyone, we've got to meet the central agenda. And actually, what's been quite amusing to me is my colleagues in DHSC, they think they're very special and they sign the contract. So we should do what they want. And actually, for me, I operate across all of health. And so I go, actually, no, we're not doing that, DHSC. You're one of 100 organisations using the system. We need to implement a solution that works for everybody. Just because you've got some ministers, we're not going to bow to your demands. We'll do what's right for the whole system.
Sarah, do you have special organisations and special individuals?
I mean, I think there are differences across the health system, right? As a consequence of the landscape, the health populations that each ICS serves, needs are different. So I think there's a degree of needing to accommodate a wide range of requirements. But I think what we were talking about there in my language is, do we need standardization, or do we need the ability to digest lots of different types of data, but as long as we've got the standards and the APIs and the policy bit harmonized, then actually we can make sense of what we get. And I think there's a couple of good examples. If I think about how we manage product information data, our product information master solution, we've got 600,000 products in there. And I think 400,000 of those, we already have unique device identification attributes, as well as a whole host of other things. So in some cases, I think it's really important that the standards are set centrally and are adopted, and we're responsible for adopting or driving the adoption of some of those standards ourselves. But in other cases, like, for example, the Federated Data Platform, that's a great example of where they're looking to set I think, the parameters, but working with lots of different types of systems and lots of different types of input data. So accommodating differences across the health system, but using the sophisticated technology that can then ingest, interpret, and come up with insight that sits across those different types of systems. So I think with different approach to the problem.
Yeah, Sarah, also more broadly across the supply chains you manage, how are you leveraging that data to improve supply chain effectiveness, but also to enable the NHS net zero goals, which we've talked about quite a lot this morning?
Yes, so I think if I just come back maybe to the resilience challenge that I talked about right at the very beginning, I think only when we've truly got the ecosystem connected and sharing inventory information on a real-time basis will we really crack that nut, as it were. Because I think what COVID showed us was actually each entity within the supply chain across the health system knew what it had, but didn't know what was left and right of it. So we knew what we had in stock, but we didn't know what was in the trusts. And when you're in a supply chain constrained world, if you can't see what's in the trusts, if you don't know exactly when information is coming in and product is arriving, it's very, very difficult to then optimize for the whole. So I think, in the future, what we would like to help the health system move towards is having greater management and control of that inventory information in an automated way, in a systems way, not on Excel spreadsheets and not with people-powered insight. No, absolutely not. I think we see the value in the need for systems both at a trust and an ICS level, and then also connecting into the systems that the suppliers already have, and leveraging the platforms like FDP to bring all of that together to help ICSs optimize for themselves, but also to help us optimize nationally and make sure that we can send the right products down the right channels at the right pace.
Just looking to the right-hand side of my screen, we've got a few extra questions coming in. Neil, one for you from George says, we utilise the spend comparison service quite regularly and find it really useful in our trust. The spend visibility tool based off AP data sounds a great idea too. Is there a rough timescale when we might expect that to go live, or anywhere where we can keep up to date with progress?
Yeah, so that is already live. That is already publicly accessible via the NHS England application library. So one of the changes that we made to align better with some of the changes that we've made is we want to make it easier to sign up to the spend comparison service to get access to it. In order to do that, we have migrated the service away from a platform hosting perspective from NHS Digital to NHS England. So if you are an NHS employee, you work somewhere in the NHS, you can go to NHS England application library, do a quick Google search or Bing, not being favorites here. You can then create an Okta account. With that, you can register. If you just search for spend comparison service, you will find spend comparison service purchase order, which is the classic product that's already been there for some years. We're working on that as well. And then the accounts payable side, we've got some basic high-level expenditure visualizations that are accessible as well. We also have a public beta that's a slightly different visualization engine, has much more functionality to it, and that's basically what we're slowly putting in that Okta environment. If you want access to that, by all means, ping me an email. I'm not sure if my email will be publicly available after this, but if you search for me in the global directory, we will make sure that you're set up with that as well. And that is also accessible via the central commercial function hub on NHS Futures.
Brilliant. That's great. I'm sure the team behind the scenes will make sure you get hooked up there. And a question for Steve. Laura says, hi, Steve. What is the system you've rolled out for improved collaboration and centralization of data?
Yes, so the platform that we are implementing, the application is an application called Atomis, and it runs on the Salesforce platform. The way that the system works, it's basically a federated system and it's multi-tenant. So what we're able to do is set up, for example, an ICB and an ICS with the child organisations as the trusts that are within it. What that means is that anybody that's authorised to be within the ICB or ICS environment can actually look at data for each of those trusts. They can then collaborate through that. Another example of that is within the system, there's a separate data analytics app where the user can see fields that we publish through the transparency agenda. So contract start date, end dates, supplier, etc. And we're able to provide access to that to allow people to look at aggregated data across the whole of the user base. So if somebody was interested in, for example, the fact that a table supplier, a supplier that provides tables, is at risk of going bust, or all their directors are in court for fraudulent activity, they can notify other colleagues across health and say, actually, this is a supplier that we have a concern with. You can either decide what approach you're going to take to address that, or you might join our strategic approach, as government did when we had the collapse of Carillion.
And just a final thought, perhaps, Sarah, you can take this one from Tracy. Tracy says, I completely agree with the process of creating reduction of buying systems. However, how will centralised procurement ensure that suppliers are compliant with standard, etc., due diligence?
So it's a core part of what we do when we put contracts in place. We've got a fairly rigorous process. So I would expect any of the standards that you're complying with are also mirrored within the national entity that I work within, at least.
Brilliant. Well, that was perfect timing. It is 2:30. So thank you very much to Sarah and to Niels, and also to Steve. It's time for our last break of the event. Thank you to everyone who stayed with us from the start. Thank you for your questions too. This is your last chance to get the most out of the event by utilising all the functionalities on the NHE365 platform. So whether you want to make a connection or share thoughts in the live chat, that's what you can do. So we'll take the break now, and I'll see you in just over half an hour. Thank you.